Hello, everyone, and welcome to World Coma Day 2025. I'm Brooke Murtaugh. I'm an occupational therapist at Madonna Rehabilitation Hospitals and the Brain Injury Program Manager there in Lincoln and Omaha, Nebraska in the United States.
Hi, everyone, and my name is Gisele Silva. I am a stroke and neurocritical care neurologist based in Brazil, São Paulo, at Albert Einstein Hospital at the Universidade Federal de São Paulo. It's a great pleasure to be here with you, Brooke, and to be with everyone.
Thank you. So today we are going to be sharing, Dr. Giselle and myself are part of the Caring for the Patient in Coma, or COPIC, group through the Curing Coma Campaign. So this group is really focused on the daily, hour-to-hour, minute-to-minute care of the patient in coma or disorders of consciousness at the bedside, not only within the ICU, but our group is really focused on that care across the continuum. So we want to introduce the World Coma Day audience and our colleagues to our technical work group and do an overview of our first gap analysis paper that was published in late 2024. So our title of our paper that was published in the Neurocritical Care Journal, Caring for Coma After Severe Brain Injury, Clinical Practices and Challenges to Improve Outcomes. And that's what we're going to cover today. So just for the attendees today who are taking in this presentation, there is a QR code to take you directly to our paper, and you can see there the title out of the Neurocritical Care Journal. So to give, again, a little bit of overview of our COPIC work group, we are focusing on care, not cure. There are other groups within the Curing Coma campaign that we've heard from in the past, as well as maybe this year in World Coma Day, but we're really focusing on that day-to-day care and not cure. And so we want to know and focus on what is involved in the bedside care for the patient in coma. You know, are there standards that clinicians are following? Is everybody doing similar interventions? What is the timeline for those interventions? Or as a past study has alluded to, is everybody kind of doing their own thing, and there really isn't standardization or systematic approaches to care for that individual in coma or DOC, not only again in the ICU, but along the whole entire continuum of care. Does the bedside care that we provide impact outcomes? We really don't know. There's been a multitude of studies out there looking at long-term outcomes, whether it's emergence from DOC, what are the functional and quality of life outcomes, but there really hasn't been a focus on, are those outcomes related back to the types of care and interventions that they received in the ICU? I think we can make some theories about that, but do we really know? And that's another area that our group wants to focus on. We are a multidisciplinary group. So we're very unique in the fact that we do have neurocritical care physicians, nurses, but we also have some post-acute and rehabilitation disciplines such as occupational therapy, physical therapy, neuropsychology, physical medicine, and rehabilitation physicians. So we're an interdisciplinary group that are clinicians that practice across the continuum of care. So that provides us a unique opportunity as a group to take that very wide lens view of bedside care and day-to-day interventions for individuals with DOC. So along with that, and what our group is comprised of as far as disciplines is, again, as I said earlier, how do we know what really happens at the bedside for each individual patient? Or is there a approach to care among organizations or level of care? Is there a consistent approach to care for ICU versus a step down level of acute care versus post-acute care, and whether that post-acute care is occurring in an inpatient rehab facility, a skilled nursing facility, again, talking about levels of care that I'm familiar with in the United States, and really starting to conceptualize an idea of what does that daily care look like and how is it impacting outcomes. So how we started that approach with our group is completing a literature review and a gap analysis, and really looking at what are themes that are out there currently in the literature, focusing on bedside care. And the themes that we identify, are there gaps that we also identify, and maybe areas of care that really aren't focused on, that we as a group have questions about. The things that we found is the care models and pathways differ by country and health system. Again, we are focusing not only on the acute continuum of care, but also post-acute. And then as a group, we worked to come to a consensus on the gaps that in care that we identified through the literature review, that we as a COPIC technical work group wanted to focus on in future projects, to see if we can advance the science and the quality of care to fill those gaps. So the gaps in care that we identified were, the first area was clinical expertise, and that we understood and identified that the clinical expertise and how those clinicians who are treating at the bedside, what's their level of knowledge base. I think we all have our own experience, regardless of our discipline that and specialty, that we probably gained our knowledge and know-how and our competence in working with patients in coma and DOC on the job and in our training, not in the classroom. And so we know there's different levels depending on how we trained, our exposure, and who trained us on what level of expertise we have in working with patients in coma and DOC. Assessment and monitoring. So we found that as a significant gap of, how do we assess patients? What's the consistency that we assess patients at the bedside? How are we monitoring these patients, and how and what we're finding with bedside assessment and monitoring impacting outcomes? Timing of interventions. Does the timing in which we do the bedside care, regardless of what that bedside care is, have an impact on patient outcome and how that patient responds to interventions? Use of technology. So how are we using technology at the bedside? And now with big data harmonization, AI, those aspects of healthcare, how is that impacting our use of technology? And can we gain more and more information to develop understanding of bedside care and how it's impacting our patients? Family communication and engagement. We know having family at the bedside and their engagement and participation in care, their understanding of what's happening with their loved one, because they essentially are the surrogate decision maker for this individual who doesn't have the capacity to make healthcare decisions at the time. And so how does their understanding and engagement in the care that's occurring with their loved one impacting what's happening as far as future care decisions and long-term outcome, whether that's withdrawal of care or pursuing aggressive care and moving that patient along the care continuum? Religion and culture is closely related to that. That's another area that we found that we really don't have a great understanding of, is how does that family and patient's religion, spirituality, and ethnic culture impact care decisions and how that individual is cared for, not only in the ICU, but along the continuum of care. Systems of care. I think that's a huge topic that we're all looking at in our own individual roles, countries and healthcare systems, but how does our respective system of care within our country and our geographic area impact that individual's care? Transitions to post-acute care. There's quite a bit, especially in the United States, of work going on right now trying to increase access to post-acute care, because we know for sure in the United States healthcare system that there are significant barriers, especially for individuals in coma and disorders of consciousness, in being able to access specialized post-acute care and rehabilitation that can have a very positive impact on their long-term outcome. This is a table of those areas identified in a more microscopic granular level of what we found with our literature review in the current state of practice, the gaps in knowledge and evidence, what the future research needs are, and practical implementation in clinical settings. So how can we move the needle forward in each of these areas? So again, if you want more detail, again, we encourage you to go to that QR code in the beginning.
Thank you so much, Brooke, for this great introduction. And first of all, I feel so proud that we could actually navigate upon a literature. There was not much into it. So when we started the discussions on our group, so the question was what we do today and now for our patient. Of course, there is much to be done regarding research, and the Curing Coma group has different work groups working in future research. But in the meanwhile, we are treating our patients and they are at the bedside, and we have to know how we best treat them and to get some conclusions and some consensus. So as we described, clinical expertise was the first topic of the care of the coma. Of course, for treating a patient in coma, all the healthcare professionals, they have to get expertise in treating disorders of consciousness. This is a highly specialized field, and we need a systematic, accessible disorder of conscious education and training. So this was definitely a gap that we identified. We found a high variability in practice approach regarding assessment, diagnosis, prognosis, and treatment for our patients. And so the solution would be to try the more we can to standardize the training and the measures that we do at the bedside to improve consistency. And we know that much that we do, not only in the acute phase, but also in the transitional and post-acute phase of patients with disorders of consciousness, is to assess and monitor such patients. So this is the most important things we do in the ICU, in the neuro ICU, and transitioning of care, because we've got to know if our patients are getting better, if our interventions are working or not, and they guide our clinical decision making at the bedside. So we found that when we go to clinical examination, there is also a wide heterogeneity of assessment practices, like using different scales for different diseases. And of course, it's not going to change from day to day, but we have to try to standardize this as well, and also to work more on the detection of cognitive motor dissociation and covert consciousness. So this is a big topic, and in the reality of the today neuro ICUs, we've got to be prepared to try to identify such patients. And finally, to have important data collection and harmonization. As you said, artificial intelligence is going to bring us a lot of information on things that maybe we didn't even know they were important. Timing of intervention is another high importantly field in our practice. So does the timing of what we do, procedures like tracheostomy, like craniotomy, like simple things that you do day to day, like suctioning the patient or sedating cessation for clinical examination, those practice change the way that those patients are going to be in the long-term basis. So are we doing it good? Can we actually incorporate those timings in our clinical practice, and not only in research as well? So we need much more research. We have punctual research regarding each topic, but we have to understand the importance of when we do things to our patients. And so we leave the world of technology, this new brave world that we are living, incorporating artificial intelligence into our practice, is going to rapidly expand the way we use neuroimaging and neuromonitoring. And we are, living this right now. So the way that we interpret neuroimaging, CT scans, perfusion scans for stroke are completely different than the way we did it 10 years ago. And that's good. So what most beneficial and what information is beneficial for the use of technology? How can use this in our practice? How we can get more data, how we can get it accessible, and how we can get it even in settings that are not of high-income countries. So it's very important that we know that most of the disorders of consciousness, they do happen in low and middle income countries. So how do we make this technology accessible to everyone? And as you said, family communication and engagement is a great part of our practice, and it was for a long time seen as something that was not technical, that we could not teach and could not, learn, but of course we can. So communicating well with families is really, really important for us to understand, the desires of our patients. Everyone is different, so thank God it's not very good to be similar. So it's very good to have diversity, and we have to respect it. We have to understand, we have the families and understand diagnosis, because by understanding, they are going to help us to plan care and to establish, a plan for that patient that's actually something based on what the patient believed and whom the patient was before, being in the situation of having a disorder of consciousness. And as you said, religion and culture is very, very involved with this. So how and why should we be approaching this? Do care providers have an understanding of the religion and culture of their family? And it's very, very important also to be cultural sensitive to what our patients are telling us, and to give them times, because sometimes they need it, and we are in a hurry of treating very, very, many patients in the ICU with severe diseases, and we've got to pause and listen to them and respect, their beliefs and their culture as well. And of course, for this all to be improved, we have to have important, well-organized systems of care. I think that we have very good examples of systems of care that were very well developed, like the systems of care for stroke. So should be using more and more telemedicine, telestroke, as telestroke did. We probably can do. So are there other countries that can provide better systems of care than the ones that we are looking for? We have different systems of care if we compare Europe, US, and even middle-income countries can do very, very high-level neuro-ICU care with not so much money. So we've got to be learning from whom is doing it. And transition from acute to post-acute care is actually a real gap, not only in the United States, but all over the world, even worse in countries that don't have rehabilitation systems very well established. We have to create and to work with researchers to support post-acute specialized rehabilitation and training. And then we've got to think globally. How do post-acute services, do they vary globally, and how can we standardize measurements in this field as well? So I think, Brooke, that we have a lot of next steps, important next steps. So I'm really glad that we are working on more to answer, doing a systematic review on all those domains that we identified as gap, design a prospective study based on bedside care to answer such questions that are so important for the care of our patients today and now. Thank you very much for everyone's attention.
Thank you. Of course, it's going to take a lot of work to identify knowledge to fill these gaps, and what does research tell us. So if you're interested in getting involved in our COPIC work group, please reach out to us. Happy World Coma Day, and thanks for joining me.